And we are now broadcasting. Welcome, everyone. My name is Megan Lucas, and I have the privilege to be the CEO and Chief Economic Development Officer for the Lynchburg Regional Business Alliance. Thanks for streaming in for our Wednesday at 1 webinar series. And we have a real treat today, discussions from the front line, and you won't be hearing much from me. We have Chal Nunn, who will be our facilitator today. Chal is the owner of Executive Coaching and Consulting, and he will be has a very wonderful background in the medical field. I believe it's officially Dr. Nunn, correct? Is that how I should respond?
Correct.
Dr. Nunn's background is in medicine, and so he is far better designed to lead this discussion than I am. I have no medical training. I like to just rub dirt on everything and call it good to go. But really, thanks everybody for zooming in today. We're glad you're here. Before I pass it to Chal, I do want to give everybody just a few updates. Please continue to visit our website, lynchburgregion.org, and click on the coronavirus hub page. That's where the timely, relevant, and information is available for you and your businesses regarding anything coming out of the governor's office, the state offices and departments regarding potential opening, renewal, and recovery. We also this week have dropped the business recovery quick guide, so please take a look at that as well as a valuable resource as we chart a course towards reopening. Other activities that are occurring you should be aware of. This Friday, we are really honored to have Senator Werner do a virtual business roundtable. That is open and available to all the members of the Lynchburg Regional Business Alliance, and that you can register for that. And anything I talk about, you can register for on our website, lynchburgregion.org. Additionally, I want to let you know that on May 21st, Christine Kennedy will be hosting Lessons with Leaders, and the leader we'll be focusing on that day, or featuring rather, is Dr. Nancy Hubbard. Dr. Hubbard is the Dean of the School of Business at the University of Lynchburg and has a variety of topics to share with everybody. Also on May 21st at 1 o'clock will be our Diversity, Equity, and Inclusion Roundtable presented by Genworth. That also is facilitated by Christine Kennedy. For any information you hear today, please don't hesitate to reach out to the Alliance. If you have any needs, again, we're your resource and we're here for you. With that said, it's my pleasure to toss it over to Chal Nunn, our beloved facilitator for this afternoon's discussion. Chal?
Thank you, Megan. Appreciate that. You know, I've been here in Lynchburg for about 20 years working in the healthcare system. One of the reasons I came here is because we have such a strong healthcare system. And I thought it would be appropriate for us to talk to a couple of our frontline caregivers in the ICU who are facing this crisis head on. So we have with us today Jeremy Hardison, who is our physician, who's the critical care lead at Centra, and Ray Newbill, a nurse, who's a frontline caregiver as well in the ICU and the shift manager there. And I want to tell you thank you for what you're doing and give you this opportunity to share with us who you are and what you do. So my first question to you is would you just tell me a little bit about who you are, where you're from, and how you ended up in your role in the ICU. We'll start with Ray.
Hi, so I am actually from Montana, and I have tons of family out this way. I always thought that I would end up back in Virginia. Grew up there, went to school there, but I actually came back and went to Lynchburg General Hospital School of Nursing and graduated there in 2006. That is now Centra's School of Nursing. So I'm very proud to be alumni from there. I thought it was a great program. I started on the surgical med-surg floor and worked there for a year just to get my feet under me, learn what nursing and taking care of patients is all about. And then after that, I went to the medical ICU. And so I have been there in the medical ICU for 13 years. In the last 3 years, I've played some role in a little bit of management, which has been great because I kind of get my feet in both doors, and I get to still love on my patients, take care of my patients, but advocate for my nurses also.
Thank you, Ray. Glad you came here from Montana. How about you?
Me, I'm a North Carolina boy. So I grew up in North Carolina, did all my training at Duke University, undergrad all the way through. I know Child's a Duke fan, so.
We both did.
Did all my residency and ended up going to a fellowship in a combined program of pulmonary and critical care. Moved here to Lynchburg also 14 years ago. Joined the group Lynchburg Pulmonary Associates here, which does a combination of pulmonary and critical care. About 3 years ago, transitioned to being employed by Centra, and now I do full-time critical care with some administrative work as well.
Okay. You know, it's always nice to have another Dookie in town.
There's a few of us.
Yeah, a few of us. I think people want to hear what life is like on the front lines taking care of these patients and how it's different than your normal day in the ICU. Ray, from a nursing perspective, can you share with us first, what it's like for you as a nurse and your team and all that kind of stuff with these patients?
Yeah, there's actually several levels to that question. So bedside nurse in a COVID unit looks a lot different than what it used to look like in a regular ICU. And the main part of that is just having to don and doff our PPE and make sure that we do it in the right order and try to figure out how do we limit exposure to ourselves, which also keeps our coworkers safe. So with that, we have to figure out how do we do the best care that we can, clump all of our care together, figure out how to go in and take care of our patients, whereas we used to kind of go in and out of the room and it was never a big deal. We've even tried to figure out how do we keep our IV pumps and everything out of the room using extension tubing, because there's a lot of medications that we're constantly adjusting up and down. And so how do we do that without having to go in and out of that room? As far as like, what does it look like for a charge nurse? That's even different. We're having to stock our own supplies, order our supplies. We have to clean our unit daily. We just don't have the resources inside of our unit like we used to. Those resources are still there, and we work very closely together to try to figure out how to make our units run the best. They're just a little more behind the scenes than they used to be. And then as far as regular ICU nurses that can't come into COVID, life looks a lot different for them too, because they've kind of been displaced outside of the unit that we chose to be COVID. And so they are traveling around to different ICUs that they've never worked in. They're getting to learn different diagnoses and how to take care of those patients. And so we've all really come together to figure out how do we take the best care of these patients and how do we take the best care of the patients that are outside of the ICU and have to mingle together. We're now working in the COVID unit with volunteers that are coming from all different ICUs, which is really great. But you're working alongside somebody that you may have just met that day. So that's a little different also. But I think everybody is really showing a lot of grace towards each other and working together and figuring out what is absolute best for our patients. So I think that is something that we strive in, and we just, we were trained to do things that we didn't know we were going to do, and you just keep rolling with the punches, and it changes every day, and you just keep going.
Okay. Jeremy, what about from your perspective as a physician? Is this not what you bargained for when you probably took the job?
No, I didn't have this in mind. On the other hand, this isn't, the disease process isn't that different than some of the diseases we've taken care of before. The difference is that this is something that we could take home to our families, or that we could accidentally give to other healthcare workers. And that's what's really made it different. So we've set things up, usually what happens is there's 4 different intensive care units. And if you are a critical care doc, you'll go from one to the other to the other.
Yeah.
In this case, in order to protect ourselves and the rest of the hospital, when we come on staff, we come in, we change into scrubs, we go into what we call the hot zone, which is the ICU that is just COVID, and we stay there for the entire 12 hours. We don't leave for going to the cafeteria, we don't go to different ICUs. That is all that you do, is take care of those patients. And you do that in the safest way so that you're not bringing things in and out. We minimize a lot of people coming into the ICU. So normally we have a lot of ancillary staff. We have people who help draw blood, people who do x-rays for us, people who do simple things like speech therapy and physical therapy. And in this unit, we've essentially not used them because we don't want to unnecessarily expose them. So that has been a very different way of having to take care of these patients than we've had in the past.
Mm. Have you used telemedicine and things like that to remotely allow consultants and others to help you?
Yes. So when we have, for instance, we had a patient recently who had a large stroke. We use telemedicine in two ways. One is so that they can remotely examine the patient and give us advice. Obviously, if they have to come to see the patient, like one of the cardiologists will come in and help us with that. But for the most part, we try our best to minimize the number of people in the unit. So we use telemedicine for that. And we also use it to help communicate with families so that families can see their loved ones.
Yeah, what have you done with visitation policies kind of thing for these kind of patients and units?
Ray, you want to answer that one?
Sure. Unfortunately, we cannot allow any families into the COVID units, which has been really hard on our patients, the families, and also the staff. That's something that we've never really done before. And as nurses, you feel like your job is to take care of the patient, but your job is also to take care of the families. And so we've really, Centra's been very supportive on trying to figure out how to open up our policies around videoing and pictures and using FaceTime, using Skype Business to try to be able to have these conversations and for families to really see their loved ones, to either be able to have conversations with the loved ones or just to see what they look like. So we may have a patient that's on the ventilator and flipped over on their belly and on a ton of drips, and that's like the worst case scenario. And for family healing and for family to understand and be able to make decisions, they need to be able to see that. And so we'll actually go in and update the families on video through either FaceTime or Skype Business, and they can actually see what their loved one looks like, and we can point out what the drips are, and we can show them the monitor, and it just allows them to kind of be there in the moment.
Yeah, that's a dramatic change from what we used to do, because I can remember when units were very closed, then we opened them up to have families there all the time, and now you've had to go back to the old way. What do you do at the end of the day and end of the shift to help decontaminate yourself before you go home and you're exposed to everybody else? You get out in the hospital. I understand gowning up and going in. So it's kind of a multi-layer question. How do you conserve protective equipment? We don't have an unlimited supply. And what do you do when you leave to protect others as you go out in the community and your family?
Well, when we leave, so when we're there, we actually change into hospital scrubs now. So we're not bringing our scrubs in and out. Most of us wear caps of some sort. So at the end of the day, we go and we change back into either scrubs or whatever clothes to go home. A lot of us are actually taking showers there in the hospital. It just depends on what our comfort levels are. Most of us, the shoes come off outside the house, or there's a certain part of your garage or a mud room that is like kind of your offloading place for your shoes and your bag. But we really try not to take anything out of the unit. We try to take showers. There's no hugs, no kisses before that shower is taken. Just trying to figure out how to separate yourself. We've got a couple that actually are living separate from their loved ones. And I think it's just something that you have to decide what your chances are and how careful you're going to be. And most of us are taking our temperatures, or at least looking for signs and symptoms and kind of monitoring that twice a day, and just trying to be smart about it.
Jeremy, anything you want to add?
No, I think she's right. The Centra has done a great job supporting us. So they've set up changing places. So you come in, they supply us the scrubs. You're in the scrubs all day. You change out of them, so you're not bringing those home. Those don't even leave the warm zone of the ICU. Whenever we're in the hospital outside of the ICU, even in the ICU, we're wearing masks the whole time. Because part of the concern isn't just what you're being exposed to from the patients, but if one of our nurses or physicians was sick, they could expose a whole bunch of our caregivers at one time. So we all wear masks in the unit. I check my temperature twice a day, every day. And I do very similar. I come home, I go straight to the shower, new clothes. I have my shoes I wear in the COVID unit, those stay in the hospital. So you try to separate out, but I'm not living separate from my family at this time. I'm just trying to be as careful as I can.
Have we had any caregivers pick up COVID that you know of?
Not in the ICUs or not in the ICUs. I think there have been some incidences of exposure where a patient who we did not realize had COVID exposed certain caregivers. I'm not sure if any of them came down with the disease or not, but I know they self-quarantined.
Okay.
But the ones that were identified as COVID early, the ones that ended up in the ICU or on pulmonary floor, to my knowledge, the steps that we have put into place, I'm not aware of anyone from therapy practitioner or nurses that have become ill or even had to quarantine.
Okay, good. You know, we also see the overwhelming nature it's hit New York City, and it's in the news all the time, and the ICUs are packed, and it's just like chaos. What's our census been here? What's kind of been your experience here? I get the sense that we are at a lower level, and it's been handleable.
We've kind of gone through the whole spectrum, I guess. When this first started and we started looking at models, I mean, there were quotes of us having 70, 80 intubated COVID patients at one time. And for those who aren't familiar, the entire ICU census in Lynchburg General is 48 beds. So this would be a massive increase in what we're usually capable of handling. And again, credit to Centra. They did a lot of work putting together plans about how we could outfit other units to ICU. I had several physicians who volunteered to help come on and help us take care of these patients if we needed to. We rented a bunch of ventilators to have them on hand if we needed them. And I'm thankful that we haven't had to get to that point. We got a maximum census of around 15 at one time. It ended up that a decent number of those didn't have the disease. So the hard part with this is the testing part. You know, in the beginning, it would take us 2-3 days to get a test back. So if you were suspected of having the disease, you had to be in our ICU. And that meant your census kept getting bigger and bigger as you're waiting for the test to come back. Now we have the ability to get the test back relatively quickly, within an hour most of the time. And so we've been running anywhere from 5 to 8 or so coronavirus patients in the ICU at one time, but they all have the disease and they all tend to be very sick and they stay with us for quite some time.
Right. That's what I was going to ask next is I'm used to seeing critical care patients from the flu over the years. And what's different about these patients and the way they present and the way you manage them? I mean, we're hearing about COVID toes and low oxygen saturation, less use of ventilators, all that kind of stuff, children's syndromes, blood clots. What are you seeing? What do you think?
It's been all over the place. And the problem is trying to discern what's real, what is just something one person saw 3 times, what therapies might be useful that haven't had clinical trials done yet. It's been difficult. I'll tell you what's unusual about these patients is they tend to come in with very low oxygen levels, but not feel short of breath. They have what we call very compliant lungs, meaning it's not hard for them to breathe. They just have really low oxygen levels. We've also seen several cases of patients who the virus affected their heart, so they have cardiac problems. And somewhere around 10 to 20% of them also have kidney problems and end up on dialysis.
Right.
But ultimately, the majority of our patients, what you see is they come in, they're on, a couple liters of oxygen, and then 12 hours later, they're on 10 liters of oxygen, and then 12 hours later, they're ventilated, horrible, what we call ARDS or severe lung disease, requiring us to do a lot of kind of mechanics on the ventilator, and then a very slow wean, usually over a couple weeks as they slowly get better from that. So we've been treating the lung portion very similar to the way we always have, although the physiology seems to be a little bit different. I think the underlying principles are still the same. But they're not coming in with horrible sepsis, with low blood pressure. We have had a couple of neurologic cases, the clots that you talked about. So we've had strokes, we've had patients with seizures. And we have been empirically treating them with blood thinners. Those are the sicker ones, in the hopes that we're preventing problems with clots. But without definitive evidence out there, a lot of it is just kind of best practice guidelines where you look at what evidence you have and hope that you are making the right choices.
Ray, what about from a nursing perspective? You're with these patients so closely. How are they different than your other ventilated patients from a nursing standpoint?
It's actually interesting because the nurses and the doctors who are working in the unit, you can almost look at these patients' lab work, and not to say that you make a game out of somebody being sick, but you can almost, we look at them and we're like, no, this is COVID. No, this is COVID. You just know, because even though it's different in different areas, and you're hearing all these things that, you know, the COVID toes, which we actually haven't seen, but you're hearing all this stuff, but you really can almost pick them out. And so the other thing is that they are sick for so long. So the nurses are getting to where they can almost point things out before they actually happen.
Right.
And part of that is because we're all working in that area together. And so you're seeing these patients week after week. And so we're just getting very knowledgeable about what their needs are and what the next step is. And we might have somebody that we think is going to go out to med surge tomorrow or today, and we're like, no, this one is following the same trend everybody else has. I really think by tomorrow they're going to be on a ventilator. I mean, we just are starting to learn them. The other thing that we're doing is when we flip them over on their belly, that's called proning, which we do for the flu. It's just a supportive care for this severe lung disease. And we're getting very used to doing that, which we might not have all been used to doing it before. But just figuring that out. And then I think the other aspect still is figuring out how do you involve the families and how do you be supportive to the patients. It's really hard to feel connected to the patients when you've got this big face mask on and goggles, excuse me, goggles on and a gown on. And so one of our nurses went on our Facebooks and took pictures of all of us off of our Facebooks and made big pictures that actually clip on the outside of our gown so that our patients can see what we look like, and just try to figure out ways to connect with them. And it's different when you're standing on the outside and they have a question, and so we're kind of knocking on their window asking them what they need through the door, which feels so completely wrong, but you're just trying to figure out how to make it feel normal again.
Well, it makes me thank God for nursing. Make life worth living. You know what? I've been hearing a couple of questions. Do you feel like that the death rate from this is higher than it is with the regular flu? Have you seen that? And what is your estimate that it is? I know it's hard to know because we don't know the denominator. What do you think about that?
I think of patients who end up in the intensive care unit with COVID versus the flu, we are having a higher death rate for COVID than we did with the flu. So, you know, if you end up on a ventilator from the flu, it's hard to compare the two, I guess. But I'm just saying, all the patients we admit with horrible flu and lung disease, they tend to get sick, but they also tend to get better relatively quickly. You know, 3, 4, 5 days later, you're taking the tube out and you're doing okay. They don't have the same heart and kidney problems that these guys have. These guys' lungs, they're just like concrete. It takes a week, 2 weeks, 3 weeks for them to get better. And during that time, they have all the possible complications you can have in the intensive care unit. So I think it's not just the virus that's causing the mortality problems. I think it's all the associated things that come along with it and the severity of the lung disease. Right. So I think once you're right. I don't know what the mortality is going to be in the community. Mortality of someone entering the ICU with COVID is certainly higher than someone who enters the ICU with the flu.
I've been hearing, you know, early on death rates of 50% once you go on a ventilator, but we've done much better than that. How many deaths have we had here? 1 or 2?
We are up to 3, but one of them never ended up on a ventilator. So really just 2. And some of the reports out of New York even quote death rates of up to 90% of people on ventilators. Ours is more around the 15% range. And maybe that's because we're not overwhelmed. Maybe we have resources to be able to handle this volume of patients. Maybe we find out, 6 months from now that we're doing something right, like Ray was discussing this proning business. So just to explain that, so when patients have really bad lung disease for reasons that aren't very clear, while they're on the life support machine, we actually take them from laying on their back and put them on their belly. That has a remarkable effect on these folks. It helps everyone who has bad lung disease, but for these guys, it can make a tremendous difference in how they're doing. So if you're at an institution that doesn't do that, I can imagine your mortality is going to be much higher. So I'm guessing that 6 months or a year from now, we're going to figure out what the things we were doing right and what we weren't doing right. But compared to what numbers we're seeing coming out of other institutions, we're doing actually quite well here. Yeah,
that's really remarkably good. I think it's because our care here is so good. You know how I feel about our care. I've worked there. They're fantastic. Another question I've got, I keep hearing reports about antiviral therapies like remdesivir, ribavirin, interferon, lopinavir, even anticoagulants being used. You doing any of that stuff, or are you not?
Well, we've got it divided up into 2 or 3 groups. So for the antivirals, no. And the reason is that the only one that's been shown to be helpful isn't even available in Virginia. So we don't even have access to that. Even
that's remdesivir, right?
Correct. Yes, sir. So we don't have access to the antivirals. There was some reports early on about using this hydroxychloroquine medication. We avoided that from the beginning due to concerns about heart issues. And I think it sounds like everyone is in agreement that we shouldn't be using that. So we haven't been. There's been some reports of using anticoagulants, as you say. And there's been recent autopsy studies that show several patients who seem to have passed away not from lung disease, but from blood clots that have gone to the lungs. And so we follow a couple lab tests very closely. If those show that the patient is clotting more than you would expect, we start them on anticoagulants just empirically, just to be on the safe side. The other thing that we've just started in the last few days is enrolling in a trial. One therapy that's getting a lot of attention in the media is this convalescent plasma. The idea that patients who have recovered from the disease might have antibodies against the virus. If you were to have those patients donate plasma and then give it to someone while they have the virus, it could help clear it faster. We at Centra, we just this week have teamed up with the Mayo Clinic to get access to that. We've signed up 3 patients for that. So we're going to start using that. The first unit should probably be given this week. So we have been using that. What am I missing, Ray? Did I leave out anything else?
I don't think so.
Oh, we are using the IL. There is an IL-6 blocker that early on people thought might be very useful for a cytokine storm, tocilizumab. We have used that in a handful of cases with severe disease. I can't tell whether it's made much of a difference or not, but we follow those levels closely just to see whether someone might be a candidate.
And you give that because it's the immune response that gets overactive is what kills people. So the thought is if you suppress the immune response, some degree they may survive.
Yeah, that's, what's frustrating about that is that's always been the theory for other diseases as well. So ARDS from pneumonia is like that. Septic shock is very much like that. And for decades, we've tried to find different ways of controlling that using steroids and interferon and non-steroidals and a variety of other medications to try to improve those outcomes. And all those have all failed. And some of them had significant side effects.
Okay.
We worry about that here. We think that the cytokine storm is real and it's contributing, but I have to say I'm a little bit pessimistic about whether we're going to be effective at halting that and getting it under control, since we haven't had much success in other diseases similar to this.
I had a question from someone that we used to talk about early intubation of these people, and now we have this permissive hypoxia. We allow the oxygen saturations to go down. Have you been doing that? Have you learned how to do that? Are we more tolerant of it?
I think Ray's smiling at me. I can see. I'll give you my 2 cents about that. So a lot of that is being pushed out of one particular gentleman from the Northeast. I think he's New Hampshire or Connecticut, I think. And the thought is, if you have patients like in New York, where your mortality rate is 90% if you get on the ventilator, maybe the problem is the ventilator. And so they have been trying to do all kinds of things to not put people on the ventilator. I disagree with that approach. I don't think the physiology of oxygen has changed with COVID. And I think that what ends up happening is they only put the sickest people on the ventilator, and that's why they have 90% mortality rate. We are not intubating early. We are letting people have to get up to what's called a non-rebreather, which is a full face mask. But we found that if you failing that delaying intubation any longer actually puts you at risk. And all of a sudden you're having cardiac problems and other breathing problems. So we've been using that as kind of a cutoff. If you get to the point where you need that, you probably need to be on a ventilator. And to be honest, I think that's one of the reasons our mortality has been as good as it has, because I think if you let their oxygen levels get too low, you're going to have more kidney problems, more heart problems, more other complications associated with low oxygen levels. And by being relatively aggressive early, I think we've been able to circumvent some of those complications. So my tendency from the very beginning has been, I'm not jumping into intubating everybody, but I think once they clearly have failed usual treatment, I'm not willing to let your oxygen saturations get low and just watch. I think that we have to intervene.
Sure, Ray, you guys debate when it's time, don't you?
Oh, they always know. I can tell you, our nurses are amazing, and they're amazing in many ways, but they are sitting there at the patient watching, as Ray says, they've seen other ones go through it, and the doctor's like, oh, I don't know, maybe they're like, nah, it's gonna be in the next couple hours, and they are always right. You see her smiling,
Yeah.
you know, they are always right, they always know. So smart doctors listen to their nurses.
Yeah.
Sum that up right? Is that about right, Ray?
Something like that.
Well, I'm married to a nurse. So I know the answer to that question.
You can't make our heads swell.
You know, I'm hearing you've gotten great support from Centra and their org structure and what they provided for you. You've had enough PPEs, testing, you know, all those kind of ingredients that you need to do what you do. Have you felt supported?
From a nursing standpoint, I have felt supported. They've worked really hard on planning all the way up to worst case scenario. They've looked at where do we move these patients, who's going to take care of them. They actually had our education team that built education modules to have nurses who don't typically come into our type of unit be able to take care of us, or nurses with backgrounds in a different type of medicine be able to go take somebody else's spot that could help us. They've looked at documentation and what does that look like when we're overwhelmed with patients, and what does that look like when all of our nursing staff has been taken out. I'm very proud of how hard they've worked, and they've definitely focused on the patients, the bedside nurses, the doctors, and I just kind of feel like all the way through any type of scenario. And now they're even looking at what happens in our future, like what is the next year going to look like. As far as PPE, you know, we've had different levels of, hey, maybe we should wear the mask for 1 day, or maybe we should wear our mask for 5 days, but they have fought hard to get us N95s, and you know, we just keep going back. If we don't get tested for this one, the next one that comes in, we're going to get tested and see if that fits. And I feel like they're definitely fighting for us and making sure that we have what we need.
Okay.
Yeah, I would agree. In the intensive care unit, they've worked very hard to basically, within reason, get us whatever it is that we need to take care of these patients. You know, when we needed to set up a separate unit because we thought that was the safest thing, they cleaned out a separate unit and helped us with staffing to figure out how to do that. You know, we have a respiratory therapist who's dedicated for just that unit. They've supported the physicians, you know, to support our staff to be able to, even though it's somewhat inefficient, that I'm in there taking care of just 7 patients. That's the right thing to do, and they've supported that from the very beginning. So I've been very proud of what they've kind of put forward to help us out. Anytime we have a suggestion, a concern, a problem, there's a group of really good people who come together from all over the organization to help us out, whether that's finance or security, or how do we set up negative pressure rooms when there wasn't rooms before. It's been an impressive, a very impressive group that meets very regularly, and they've also been very transparent. They send out updates to the whole organization. Here's how many ventilators we have. Here's how many COVID patients we have. Here's our decisions that we're trying to work on today. Here's setting up screening. Here's what happens if you get exposed. It has been, I've been very impressed. I don't think, you know, even thinking back of the last 6 weeks, 8 weeks, it's hard for me to think of ways that we could have done things quicker or in a better way. I think once the ball got started, once we started saying, okay, it's here now, we need to think about this, I think things moved forward very quickly. And I've personally felt very supported by the organization.
Yeah, I've seen a lot of that communication, and even our pathologists talking about testing and the
Right.
status of it, and availability, and what it means. I found it better than anything I'd find on the national news. So local information was very good. What, how do you see this? We're going to get a little speculation now. How do you see this pandemic playing out in our community over the next year or so? I think that, you know, there's all this concerns about opening up and about restaurants and what should they do and the phase and all that kind of stuff. I mean, I will ask you just your opinion about those kinds of things.
I'm worried. I think what we're going to see is a seesaw effect where we're going to open it up. And as you open up, you're naturally going to see an increase in the number of people who have the disease. And then it wouldn't surprise me if we ended up having to close back again for a little bit. I worry that the vast majority of our population within Lynchburg hasn't been exposed to this. So we're seeing, you know, patients coming in from prison systems, from skilled nursing homes. But I really worry about, you know, what happens in November with all the kids in school and all of that. What's it going to mean like when we go from 5% of the population being exposed to 90% of the population? It makes me nervous. And I think that we're going to see at least a low level of this disease for months to years. And there's a lot of very vulnerable populations out there that can be affected. So I think this is just round one. And I think that you're just going to see this cyclical version. It's just a matter of when and how much and what our capacity is. We're switching over into conversations at Centra. What is the new normal? And the new normal includes a certain number of ICU COVID patients and ICU and floor COVID patients. And that's just the way things are going to have to be, perhaps for a long, long time. So I worry. I think there's bound to be increased in local prevalence. I just hope that with social distancing and other things that have gone into place, people wearing masks, that those numbers aren't going to be so high that they're overwhelming. I'm hoping we've seen the worst, but you know, I can certainly see things getting a lot worse before it gets better.
What about you, Ray?
I try to be very open-minded from both ends. I do have several family members and friends who are sitting at home on unemployment. My mother-in-law owns a hair salon. So I try to be safe about it. And, you know, you just have to think about how many exposures could you possibly have and who are you taking that exposure to? I think Dr. Hardison's absolutely right. I think as we open up, we're going to start seeing more cases. And so what are we willing to open up? My church actually has contacted me and asked me to be on a committee board specifically for COVID and determining what does church look like. And currently they've decided that they're not willing to open back up yet. They do the parking lot services. And when you're in that parking lot, you're in your car. So I think that that's wise. And I think that if you have access to people in healthcare or somebody who knows anything about COVID and medicine, that having some sort of committee like that to help you determine when the right time is, I think that that's a good way to go about it.
How has this affected each of you personally in your home life, being on the front lines?
You go first, Ray.
So we did, from the very beginning, do the quarantining, which didn't necessarily make our family members happy, but that was one thing I was pretty strict on. We actually have a great babysitter who is coming to our house to watch our kids, and her family have healthcare providers in it, so they're quarantining as well. So we've been very blessed with that. We drive to my in-laws and wave at our grandma through the window to make sure that we don't get her sick. My husband and I actually got certified to foster care back in February, and so that's something that we decided to put on hold, wanting to make sure that we don't give anything to a child who might not have a great immune system or be malnourished. So that was kind of a hard decision to make, but we felt like it was the best decision for now. So I don't know where that will take us in the future, but I think you definitely have to think about what does worst case scenario look like. And when we look at our patients that are in the ICU, almost all of our patients have a pinpoint known exposure, and a lot of times that's a family member or a work partner. So it definitely brings it home to show how real this is and how easy the exposure happens.
Yeah, it's hard. This is one of the first times in our medical career where we have the potential to make our own loved ones sick. And so I think that's been difficult. I think it's been a lot of us, I know Ray's included in this, we've put in a lot of hours in this, not just taking care of patients in ways that we hadn't expected, but just administrative hours. How do we set up the ICU to be safe? How do we get staff? How do we educate people to make sure that we're doing that correctly? So there's been a lot of, our workload over the last couple months has been much, much higher than it usually is, but it's all for the right reasons. And I tell people that maybe this is why we do medicine. This is what we've trained for. And this disease falls squarely on the shoulders of critical care, and we've risen to that challenge. But it's not without its cost. And it's difficult to see our patients not doing well. It's difficult not having that closeness that we've had before. It's difficult to come home and try to do your best to keep everyone there safe as well. It's been a trying time, but I think we're also settling into a new normal with that, I think.
Have you felt supported by the community, and what else can the community do to help you?
I would say absolutely. Our kitchen in the COVID ICU is always full of food. We tease that we're going to be as big as a barn, or the chronically ill diabetic that's in the ICU that we're taking care of, because everybody's constantly feeding us or giving us gifts. But we don't necessarily need them. It's, this is what we do, and this is what we trained for. And these are volunteer nurses that are saying, yes, put me in COVID. That's where I want to be. I want to take care of these patients. So definitely feel the support, feel the love. We have a whole wall right outside of the ICU of posters and letters and things that people have made for us and sent in. And it's very inspiring. And I've never seen a community that's been this close and this supportive like this before.
Yeah, I would absolutely agree. Just walking by that wall every day, it has drawings kids have drawn for us. It has letters and quotes. That means so much to us, to know that the community knows that we're there and that we're helping out, and they realize what we're doing. That means a lot to us.
Well, Megan, we're wrapping up now. I think that listening to these two health professionals, you can see why I came to town. And why I think Lynchburg is such a great place to live. We have wonderful people like this taking care of us. And, you know, this is just what makes this a special place to live. And these two, you know, certainly embody that. So I'll open it back to you to see if you have any questions or thoughts or how you want to wrap this up.
Thank you so much. Thank you, Chow, and thank you, Ray and Jeremy, for joining us today. You've certainly given me a lot to think about, and the folks that have tuned in to watch. I think, Jeremy, I think it was you that made the comment about concrete lungs, and that's a really good analogy, and that's something I'm going to keep thinking about. And it is 1:45, and we need to wrap up, but I do need one clarification. Remember, I'm not the medical professional, but is there a distinction between, you know, COVID virus and lung disease? And so when you talk in terms of lung disease, and I'm thinking virus, and I wonder if you can address that real quickly. It could just be, you know, I didn't go to med school.
No, it's quite okay. So the virus causes a variety of problems in the body. It just most commonly affects the lungs.
Okay.
So people who come in end up with essentially like a viral pneumonia is their most common way of coming in. But some of them come in with just it affecting their brain or just that affecting their heart. But the vast majority we see, the biggest problem they have is with their lungs. That's where the virus tends to go.
And what is the you know, you talk about the impact of flipping a patient.
Yeah.
What is the impact? What's the positive to that flipping? What does it do?
It's amazing. So in patients whose lungs are affected by this virus, it causes part of the lungs not to open up normally. So you end up with low oxygen levels because it's not functioning. And when you flip them on their belly, that part tends to open up better. And so their oxygen levels immediately get better. It's really remarkable. It's even to the point where patients who aren't intubated, who just have low oxygen levels, we're having them lay on their belly for several hours a day. I think it just basically helps reopen the lungs back up.
Okay. Well, I have two points for you. One, when you do this to demonstrate, you totally look like Tom Cruise in Top Gun. Okay. So you have that going for you. And it's reminiscent, the technique really is reminiscent to when I was a child and I'd have a cold and my mother would flip me on my belly and just pat my back. So very interesting. I can't thank all the three of you enough for being on today's Wednesday at 1. We are proud of Centra. We are proud of the entire medical community that calls the Lynchburg region home. And we are very fortunate to have you all here taking care of us. To our everybody that is streaming and watching us, thank you for being here. Please remember that this Friday at 1:30, we have a business roundtable with Senator Werner. That is for Alliance members only. Please register at lynchburgregion.org. And then on the 21st, we'll have Lessons with Leaders featuring Dr. Nancy Hubbard at 10 a.m. And then a Diversity, Equity, and Inclusion Roundtable presented by Jen Worth and facilitated by Christine Kennedy. We appreciate all of you. If you need anything at all, don't hesitate to give us a buzz and find your alliance. Have a great day.
Thank you.
Thank you, Megan. Thank you, Jeremy and Ray. Thanks.
My pleasure.
Thank you.